Now we're moving on into the substance use disorders. I feel like one of the most commonly asked questions on step two is going to involve a lot of patients coming in with some kind of emergency traumatic event that gets them hospitalized, and then it could be maybe a really bad car accident where they had like a long bone fracture requiring fixation of the bone and stuff like that. It could be somebody who maybe had sudden heart attack or sudden bout of pancreatitis. The pancreatitis part makes it really easy because what would happen is that eventually this patient is going to, of course, require hospitalization, treatment, and then starting from the next day, day two of hospitalization, they start exhibiting these really weird, almost psychotic type symptoms. And it's always because of alcohol withdrawal, right? So that should be the first thing you should think of when you have a patient who is hospitalized, treated, things were looking fine, and then the next day, all of a sudden, they're acting weird, or they have a tremor, or they're being delusional, but it's really not delusional because, usually a patient that goes into delirium is much older, an elderly patient, and this is going to be someone in their 50s or younger. So that's something that's usually the most common thing in, as far as substance abuse disorder is tested. Even in New World, you'll see. So substance use disorder, a maladaptive pattern of substance use that leads to clinically significant impairment. It can be applied to most substances of abuse. The patient must meet 2 or more of the 11 criteria within a 1-year period for diagnosis. The criteria can be grouped into 4 categories of symptoms and are as follows. So that means that they're going to have some history of these issues even before they present to you. Impaired control, right? Consumption of greater amounts of the substance than intended. Failed attempts to cut down use or abstain from the substance. Increased amount of time spent acquiring, using, or recovering from effects. A craving, right? So they have no control. Social impairment, failure to fulfill responsibilities at work, school, or home to your family. Continued substance use despite recurrent social or interpersonal problems secondary to the effects of such use, right? So frequent arguments with the spouse over drinking or whatever substance use. Isolation from life activities due to the abuse of the substance. Risky use, right? Use of substances in physically hazardous situations. Continued substance abuse despite recurrent physical and psychological problems secondary to the effect of substance use. So you know it's harming you, but you still can't stop using it. And then the 11th group, you have your 11th set, 11th bullet point, pharmacologic tolerance, right? Tolerance in use of progressively larger amounts to obtain the same desired effect, which then, of course, eventually leads to withdrawal symptoms when you're unable to take enough of the substance. And that's what you see in a patient who's been hospitalized, right? The most common thing with hospitalization issues is that if the patient has not been very clear about the fact that they have some kind of addiction or drinking problem or something, substance abuse problem that they can't get in the hospital, the withdrawal symptoms start kicking in. Diagnosis is typically clinical and detailed history taking is imperative. Lab tests include urine and blood toxicology screens, liver function tests, and serum alcohol. Severity is determined by number of symptoms present. Now, I've seen some dumb questions where they'll tell you there was no alcohol in serum. That I've seen that. I can't remember if the question might be in one of the things we have here in the practice questions. But so just because the question tells you that they saw no alcohol in the patient's blood, but then all the symptoms are matching what is alcohol intoxication, then just pick it, right? Don't ever force yourself to fit some kind of scenario into an answer choice, right? I have time and again, I'll tell you, this is one of the big skills you have to gain before the day of your step, whichever step, 1 or 2. When you're doing a UWorld question and you have some good idea of what's happening to your patient, and then you look at your answer choices and none of them really seem to match, and there's that one answer choice you may have no idea whatever it is, right? No idea whatever it is. That very well could be the correct answer choice. It very well could be the correct answer choice. So let me show you something actually. Let me see if I can find it. This question that I'm about to show you guys is actually a perfect example of the scenario. Now, it won't share on Discord, so I'll take a screenshot to show on Discord. Let me see. I'll just paste it right here, and then everyone can see it. So take a look at this question. This is a UWorld question that I was working on with a student yesterday. And if you look at the question, it's very interesting. 35-year-old woman comes to the office for her first prenatal visit. The patient has been married for 8 years and has tried to conceive for the past 3 years. For the past few weeks, she has experienced morning sickness and has had abdominal distension and breast fullness. Her last menstrual period was 2 months ago, and a home urine pregnancy test was positive. She has no medical problems and has had no surgeries. She takes the prenatal vitamin daily. She doesn't smoke or use drugs or anything. Vitals are looking good. BMI is good. Physical exam shows a soft, non-tender, tympanic abdomen with no masses. Bedside ultrasound reveals a thin endometrial stripe, which basically is a sign that you're not pregnant. 2 office urine pregnancy tests are negative. Which of the following is the most likely diagnosis? Now you look at all your answer choices and you kind of, you might not even be 100% sure. Like, it's kind of weird, right? What's happening? So this is a psychiatry question, right? It's really strange. She came in for a prenatal visit. She's been married for 8 years but is having difficulty conceiving, right? 3 years she's been trying to get pregnant, not happening. Today she's really excited. She's like, she did a home pregnancy test and it was positive. And you're checking everything and there's no pregnancy, right? The ultrasound doesn't see anything. The office urine pregnancy test doesn't see anything. So obviously, very obviously, she must not be pregnant, right? You can understand the fact that she probably either misread the test or something, right? Because either she misread the test or she's psychotic, whatever the issue is, something happened, but she's definitely not pregnant. So then you started wiping out answer choices. Early pregnancy, that's bullshit. Early pregnancy has super high beta ACG. Pregnancy test would actually be positive, so that's wrong. Ectopic pregnancy, well, once again, that is a type of pregnancy. You would have high beta ACG. Pregnancy test would be positive. That's wrong. Hydatidform mole, that's also a type of pregnancy. That's a molar pregnancy. Beta ACG would be high. Pregnancy test would be positive. Wrap that out. A missed abortion. To have a missed abortion, you have to be pregnant first. And on top of that, to think of a missed abortion and the various types of abortions that are in obstetrics, again, if you forgot that, right? If you forgot your different types of abortions, you want to make sure you go back and you look at the different types of abortions that occur, which is right here, right? These are all grouped in a very interesting way, and UWorld does a great job talking about them too. The missed, threatened, and inevitable, as you can see, all 3 of them have the attached embryo right there, right? Missed, threatened, and inevitable, they all have the embryo inside that you would actually see on ultrasound, first of all, which they didn't see in our patient, right? And then the missed one, right? Although there's no vaginal bleeding, no closed cervical os, and no fetal anything, because it is a missed abortion, you would see that inside. It's called missed because there's no signs. You miss the fact that you had an abortion because you can't see it. There's no signs, no vaginal bleeding, the cervical os is closed, the fetal parts are not falling out because the cervical os is closed, and so on and so on. Right, so this would just be straight up, and in our ultrasound, you would see the implanted embryo there. That might not be implanted very nicely, but it's implanted. Our patient can't be going through that because the ultrasound would see that, right? Then, of course, threatened and inevitable, these 2 have vaginal bleeding. That's usually what the patient comes in for. In the inevitable one, there's no way for you to stop it because it's all coming out, right? So dilated cervical os, products of conception may be seen or felt at the cervical os, right? Whereas the threatened one, this one, there's some chance of saving it, but it's still something that usually ends up going into an abortion. This is a threat that an abortion is about to happen. And, if the rupture here from where the implantation has occurred is not that repairable, or like if it's not going to self-recover, it will lead to a full, abortion, right? So you just try to tell the patient to do pelvic rest, right? Keep checking on ultrasound to assess viability of the fetus. As long as the fetal cardiac motion and ultrasound are good, then there's some chance, right? Last 2 are incomplete and complete, which again obviously means that the abortion has already gone way into action, right? It's just incomplete or it's complete. But the abortion has definitely started. So incomplete means that a lot of it came out, but some of it didn't come out, right? Whereas incomplete, the whole thing came out. So for saying missed abortion in our question that we're looking at right now, you have to understand. Look at a lot of people picked it. 34% of people picked it, right? I can see the immature thinking that could lead to that answer choice, but a seasoned med student that's ready to take their CK or step one soon should never be able to think of this as an answer choice. To have an abortion, you had to be pregnant first, which means that you would actually have a positive pregnancy test. And to have an abortion, that means that there has to be something in there that's going to fall out. There has to be a fetus in there. They don't see anything on ultrasound. Impossible answer choice. PCOS, completely impossible answer choice, right? Usually patients with PCOS, they're going to have obesity, they're going to have hirsutism. Ultrasound would actually show the cysts in the ovaries, so that answer choice, thank God 0% of people picked it. Premenstrual syndrome, well, that's just PMS. How does that have anything to do with the pregnancy test? So then you end up relying on picking on an answer choice you may have never actually heard of, right? Pseudocyesis, which in the question they go on to describe. This patient presents with amenorrhea, breast fullness, morning sickness, and abdominal distension, symptoms of early pregnancy, and believes she is pregnant. However, her office exam excludes pregnancy. This presentation is consistent with pseudocyesis. Risk factors include a history of infertility and prior pregnancy loss. Pseudocyesis likely occurs when the somatization of stress affects the hypothalamic pituitary ovarian axis and causes early pregnancy symptoms, or when bodily changes like weight gain and amenorrhea are misinterpreted. The end result is a non-psychotic patient who truly believes she is pregnant. The belief is often strong enough that the patient misinterprets negative home pregnancy tests as being positive. So it's basically someone who wants to be pregnant so badly that they start believing they're pregnant just because they saw a single sign or something, right? That's pseudocyesis, right? So this question is an example of the level of thinking you have to be able to get at. There were a lot of answer choices to rule out, but they were all pretty easy to rule out because they were also, majority of them were supposed to show positive pregnancy tests. This is the kind of shit that's going to happen on your test. It's going to happen over here in this specific chapter as well of psychiatry. A lot of it. You have to believe, first of all, knowing what you know, believe in yourself, understand what you're reading, and believe your first instinct of what you think is the problem. And be good at understanding the fact that some answer choice you see that you may have never heard of may as well actually be the correct answer choice, right? At which point you would have to make sure you could rule out as many of the wrong answer choices as possible to increase the chances of that one strange answer choice being the correct answer choice. Right? So you're going to see that a lot. So just because, as I said, just because you see there's no serum alcohol does not mean the answer alcohol is wrong, right? It could be alcohol still, especially if the symptoms match up. So they'll mention all the symptoms and stuff in different tables like that, and then we have a bunch of practice questions to understand it, and we'll look more into these things, right? So first thing, diagnosis, treatment. Yeah, so treatment and all that, management, all that depends on what the actual substance is. So in CK, they just go into it: alcohol, opioids, amphetamines, cocaine, PCP, LSD. They just keep going through it, and then they actually break down into it. But in step one, I like how they broke it up even better because they've actually classified the substances as either depressants, stimulants, or something that's a hallucinogen, right? So all three case scenarios are actually classified. So all your depressants include alcohol, things like act like alcohol, barbiturates and benzodiazepines, and opioids. So in general, depressants have pretty non-specific symptoms of mood elevation, low anxiety, sedation, behavioral disinhibition, and respiratory depression, which is usually pretty fatal. With alcohol, you see emotional lability, slurred speech, ataxia, coma, blackouts. You check for serum GGT, which is a very sensitive indicator of alcohol use, as opposed to the other things that are in the GIT panel of labs. And for liver enzymes, AST is more significant, right? AST is going to be double the value of ALT. So they have this mnemonic toast to alcohol, but I just have the mnemonic AST for alcohol, scotch, and tonic to remind you that AST is the one that's actually going to tell you whether or not a person is having alcoholic problems, right? Intoxication, not the worst case scenario, not a fatal problem per se. The worst thing that can happen in intoxication is, of course, trauma, because they can fall, they can do something risky like driving drunk, or the other thing that happens is aspiration pneumonia, right? Because they're so blacked out that they can just knock out in a weird way, and then aspiration pneumonia takes place, right? Because it went, their saliva went into their actual trachea. Alcohol withdrawal, however, is pretty fatal. This you need to deal with immediately. The patient can actually die. Time from last drink, 3 to 36 hours, 6 to 48 hours, 12 to 48 hours, and then after 48 to 96 hours, which is basically going to be day 3 of your hospitalization. So if you have a patient who's been hospitalized, as we discussed, it's extremely common to see these symptoms, right? I've even seen it. One of my cardiology rotations I was doing, patient was admitted the night of. I came in the next morning, and I was doing my rounds with the other students, and the patient that I was assigned, everything was fine. Labs were looking pretty good. He was doing okay, but he had a really weird tremor. His hand wouldn't stop shaking the whole time. He was telling me a story of what happened to him and how he ended up, getting in trouble or whatever. I think no, actually, that was a very special scenario. He had carcinoid, but it was mainly affecting his heart. Very interesting scenario, right? So, of course, carcinoid can affect your heart. Remember that carcinoid can either stay in the GIT, or it can come into the lungs if it passes if it already passed your liver and go into the right heart and cause tricuspid issues, right? Carcinoid has a bunch of heart things. So he had carcinoid and he was having heart problems, and he was telling me something about, I think he was on a business trip or something like that. And the whole time he was using his hands to tell me a story, but his hand was having a really, really weird tremor, right? To me, at that point, being new, I didn't really catch it that well, but it became pretty evident to me as I discussed it with my other friends, and then, of course, the attending, right, that he must have alcoholic problems. And he did. He was an alcoholic. His wife arrived later that day. She was the one that told everyone, yes, he is an alcoholic. He may have not told you guys. So then right away, of course, he had to be given benzodiazepines. Right now, if you ever have a patient that you think is an alcoholic for whatever reason, or if it's very clear that they smell like alcohol and you hospitalize them, you have to put them on benzodiazepines. You don't wait. You don't wait for these symptoms to kick in. Okay? You don't wait for the tremors and agitation and all this to kick in. You don't want your patient to be agitated with having somatic symptoms of GI upsetness. You don't want any of that. So you give the benzodiazepine as a preventative method of alcohol withdrawal, right? You're preventing those alcohol withdrawal symptoms. Because if he gets those alcohol withdrawal symptoms, that can get really bad and ugly, and he may not be, very compliant anymore at that point, and that would really suck, right? So that's something to keep in mind when it comes to working with alcohol withdrawal patients. Okay. So how long it's been will show some symptoms, but generally speaking, the symptoms are often very strange. It's all going to be tremors and stuff like that, and it's just like, why are you becoming schizophrenic all of a sudden? And that's exactly what it is, right? They're gonna have all those schizo answer choices as well, but no one just randomly becomes schizophrenic all of a sudden within the period of hospitalization, right? So if it does occur, someone became schizophrenic during the period of a hospitalization, that's the classic story of alcohol withdrawal, right? Hallucinations and everything. You want to treat them before it gets to delirium tremens where they can die. Now, barbiturates and benzodiazepines, we prefer not giving people these medications, as we said before, because of the addictive potential. Barbiturates have a low safety margin, marked respiratory depression, and treatment is just symptom management. Assist their respiration, keep their blood pressure high. We don't even prescribe these that much anymore because it's just not a good idea. Patients can overdose after getting addicted. Withdrawal symptoms are delirium, life-threatening cardiovascular collapse. So again, you try avoiding using these. A barbiturate question is usually going to be very vague. You won't know what to think of in the question because it's going to have such vague symptoms in it. You got a patient who came in for no real reason. They're just having difficulty breathing. You do a full exam and their blood pressure is high. So blood pressure is low. What are you going to do for them? So you then have to realize that it is someone who may have taken some medication that's causing them to not breathe anymore. But you see, it's really hard to ask this question, because if I tell you a patient came in with some level of respiratory depression and they're having some issues breathing, then the first thing you should think of is opioid overdose, not barbiturates. So it's a very rare kind of thing to get a question on. One of the ways you're actually going to think of barbiturate as the answer is because it won't fit the other scenarios. Just like our pseudocyesis URL question we just did, the other answer choices shouldn't make sense or not fit very, very well. And that's when you'll know barbiturate is the thing that fits well, right? Benzodiazepines, usually the question will tell you some list of medications the patient is taking, and then you can assume that the benzodiazepine is the thing causing the sudden onset ataxia and respiratory depression. You don't really develop ataxia within a day unless it was due to major trauma, right? So if someone has sudden ataxia and respiratory depression, you could think of benzodiazepine. But this respiratory depression thing is kind of shared in all of these guys. It's not a major symptom of alcohol withdrawal or alcohol intoxication, but in these three, it is a big symptom of intoxication, right? Even with opioids. So you have to be pretty careful on what you see and how you figure out what the problem is. There is not much to tell you so that you can pick either barbs or benzodiazepine overdose as an answer choice. So if a question is telling you a lot of shit and things are wrong in multiple places, everything is slow, it's probably opioid and not just one of these two. All right. Now, opioid overdose is extremely common, right? Super, super common. And there's also the problem that this opioid stuff, the withdrawal, that's the real issue. Opioid intoxication just kills the patient. Opioid withdrawal doesn't kill the patient, but then opioid withdrawal is more common in the real world because people run out of opioids. And opioid withdrawal also has a thing that occurs in kids, abstinence, neonatal abstinence syndrome, where kids present, newborns, infants, neonates present with opioid withdrawal symptoms as well in questions. So there's 3 different classes of questions to ask over here. Now, opioid, remember what it does, right? It's a painkiller. So it makes you feel really relaxed and comfortable, right? So when you have opioid overdose, you can imagine that the patient is completely ready to fall asleep, which is kind of what happens. They fall asleep and never wake up, right? Euphoria, you feel completely relaxed, no worries in the world. Respiratory and CNS depression because everything is slowing down, right? Low gag reflex, pupillary constriction, right? Because you're going to sleep, so you're not letting light in, so your eyes are closed. Pupillary constriction, pinpoint pupils give away. If you have pinpoint pupils and you're under depressant level symptoms, excuse me. If you're having depressant level symptoms, like these are all depressant symptoms of everything being slowed down, and your pupils are pinpoint, that is a giveaway for opioid intoxication, right? Most common cause of drug overdose death. How do you treat it? For acute intoxication, naloxone. And we talked a little bit about this earlier, right? Just give the person naloxone ASAP and they'll be okay. With opioid withdrawal, this is someone who ran out of their opioids, whatever it is they were using, and they can no longer find any more. So usually what happens at that point is they'll try to go find some heroin, right? That's usually more accessible than an opioid itself, like oxycodone or any of these things. And at that point, they end up overdosing themselves, as we discussed earlier, because the heroin is not exactly packaged into pills of, knowing exactly what dosage you're taking. So they can end up taking too much and end up just dead. Now, if you ran out and you can't find any more opioids, then you end up presenting with really interesting flu-like symptoms. Okay, so what you're going to look for here is a patient who was clearly abusing opioids, right? And today they present to your office with sudden onset flu-like symptoms, but then there's going to be something strange you'll catch there, which is going to be the dilated pupils, right? It's also out of place if someone is having flu-like symptoms and the question mentions a season that wouldn't really be flu season. If it's not flu season, then there's no reason the person is having flu and having really bad symptom onset all of a sudden, right? Dilated pupils occur because when you're not able to take your painkiller, you end up getting into a lot of pain. So you're in so much pain, you look like you have the flu, right? And they're in so much pain that their sympathetic fight or flight nervous system is turned on. So they're sweating, their pupils are dilated to let light in so they can fight, and they actually will fight. They'll fight you. They'll actually, there's a risk that they can attack you. If they're in your clinic and you're the doctor and they're here and they're begging you to give them opioids and you say no, they are dangerous. So be careful. Don't just say no and stand in front of them and they'll just end up slapping you. Walk away, tell them you'll be right back, get security, then come and talk to them. I'm going to have to ask you to leave because you're clearly going through a problem here, and that's it. Now, what the actual ethics answer you're going to pick really depends on the list of answer choices and the real scenario that's occurring in the question. If the patient is not being hostile and they're not about to slap the shit out of you, then you can actually have a full discussion with them about how you can give them treatment, right? Treatment here, you can see naloxone is not the answer choice. Here you have methadone or buprenorphine. Buprenorphine is usually the best answer choice to pick for someone who's having these withdrawal symptoms. Buprenorphine is a partial agonist, so it gives some of the benefits of opioid, but without causing more addiction. Right? So it's a great thing to go with. Now, neonatal abstinence syndrome is a mom who just gave birth to a newborn, and the newborn is not stopping crying, has also some flu-like symptoms, the watery nose and stuff like that. And the number one symptom there is that the baby's not stopping crying. The baby just keeps crying because the baby is theoretically in pain from opioid withdrawal. And the best thing you can do for that baby is also just, symptomatic management, right? Because you can't really pump the baby with opioids to give them what they need. You just have to symptomatically manage them. Hopefully, eventually they get better. Okay. So that's kind of some of the stuff we're seeing here as well. Same stuff, right? Alcohol, disinhibition, emotional ability, slurred speech, ataxia, aggression, blacking out, which can lead to aspiration pneumonia, hallucinations, memory impairment, impaired judgment, and coma. But alcohol intoxication itself is not what really ends up often killing people. It's what they end up doing while they're intoxicated that ends up killing them. Alcohol withdrawal can kill someone. You get tremor, tachycardia, hypertension, malaise, seizures, delirium tremens, agitation. One of the other big things here is supposed to be visual hallucinations. They should have really written that. Basically, you act like you're schizophrenic, right? Opioid intoxication causes euphoria, CNS depression, constipation, of course, right? Pupillary constriction, respiratory depression, which is life-threatening, and overdoses. They can't breathe even though they want to. They just can't. The diaphragm won't work anymore. Naloxone and naltrexone are opioid receptor antagonists and reverse the effects of opioids. May require redosing because of short half-life. Withdrawals of opioids, dysphoria, insomnia, anorexia, myalgias, fever, lacrimation, all these flu-like symptoms with dilated pupils, pilar erection, the key answer system. You see the pilar erection in an infant also with neonatal abstinence syndrome. Vomiting, diarrhea, yawning. Opioid withdrawal is not life-threatening, hurts all over, and does not cause seizures. Right? So this is a very important sentence because we're going to see a question where a person has symptoms of both alcohol and opioid withdrawal, and then they're going to ask you what you should treat first, and you should obviously treat the alcohol withdrawal first because it can kill you, and it can make those symptoms occur, agitation, delirium tremens, and seizures, which would make it much more difficult to treat you anyway. Right? Amphetamines, so that's actually then later on now. So now we're moving on to stimulants, right? So the stimulants usually cause mood elevation. They decrease appetite. So like amphetamines actually are used to help with weight loss. They can cause psychomotor agitation, insomnia, cardiac arrhythmias, tachycardia, and anxiety. If you have withdrawal, then you get post-use crash, including depression, lethargy, elevated appetite, sleep disturbance, and vivid nightmares, which also is a key giveaway for what's happening. Now, amphetamines are the main treatment for ADHD also, right? As long as the patient's parents are okay with stimulant medications, a child with ADHD can be treated with amphetamines. If they don't want a stimulant, then you'd pick atomoxetine. It causes euphoria, grandiosity, pupillary dilation. So look here, the actual intoxication, because this is a stimulant, the actual intoxication is causing pupillary dilation, right? Because you're ready to fight or flight. Prolonged wakefulness, because you're not in sleep or rest and digest mode. Prolonged wakefulness and attention, hypertension, paranoia, fever. You may see some skin excoriations with methamphetamine use. So never do meth. Meth is dangerous. And then severe symptoms include cardiac arrest, seizures, and of course here treatment is going to require you to give benzodiazepines. You're going to have to give benzodiazepines to help them with their agitation and seizures, get them under control, then continue on with symptomatic treatment. Not really going to see many withdrawal symptoms with amphetamines, not really a key thing per se. Here they mentioned just the general thing that you see with the withdrawal of most stimulants in general. They also mention here ecstasy, which you do need to know. It's the street drug name, which is mentioned separately as a hallucinogen in step 1. So we're going to see that there. But ecstasy is an amphetamine, but it's also a hallucinogenic drug, popularly used at dance parties or raves. And intoxication with ecstasy is actually used as almost basically like a rape drug. So very, very common rape drug. It causes disinhibition, hyperactivity, bruxism. Life-threatening effects include hypertension, tachycardia. So we'll see all of that. I'm going to stick to using the step 1 book rather than using what's over here, and then we'll come back to this because I don't like the way this is organized. It doesn't really do the job for you. So we'll keep going with amphetamines. There's a question here to show you how this is going to present. See, since amphetamines are used for, think of who would want to take this. There's no actual pleasure in taking an amphetamine. It's not a drug that causes pleasure like alcohol can cause some pleasure for some people. This drug is mainly going to be for wakefulness and attention, the same reason ADHD patients take it. So you're usually going to see some studious person taking it. Right? So this is a 24-year-old graduate student brought to the emergency department by her boyfriend because of chest pain that started 90 minutes ago. Her boyfriend says he has been taking medication to help her study for. Oh, her boyfriend is saying, okay, her boyfriend is talking about her, the person that came in as a female student. Her boyfriend says she has been taking medication to help her study for an important exam and has not slept in several days. On exam, she is diaphoretic, agitated, and attempts to remove her IV lines and ECG leads. Her temperature is a little on the higher end, pulse is very fast, and blood pressure is super high, 163. Her pupils are dilated. The most appropriate next step in management is what? So as a doctor, you would see the clinical scenario that's taking place. With the high pulse and high blood pressure and dilated pupils in a college student who's been preparing for an exam, it must be amphetamines. That's the number one thing this points at as the most likely scenario. So you give the patient lorazepam, right, benzodiazepine. Patients with symptomatic stimulant intoxication should be treated with benzodiazepines such as lorazepam. They provide a sedative effect, help control the hypertension, and prevent seizures. So it's the perfect medication for this. Caffeine, not really a big issue here. You're not really going to have to worry about this too much. I think all of us, even right now as I'm teaching you guys, I'm using coffee and I'm yawning a lot because I've been unable to sleep enough. We all know how caffeine works, and it's really not something that you need to study or make difficult any more than it already is. If you ever think the answer is actually caffeine, you should be 100% confident in picking that answer choice. The only reason you wouldn't be confident in picking caffeine as an answer choice is because there's something else in the question that makes you think, oh, but it could also be whatever other answer choice. If that's the case scenario, it probably is not caffeine, because caffeine answer choices are going to be the easiest ones to pick. So someone that is overdosing on coffee will keep urinating, right? And they're going to be completely in fight or flight mode, so restless with muscle twitching. And if you haven't had your morning coffee, then we all know how that feels. Difficulty concentrating, some flu-like symptoms, but not really. The mainstay of the thing is just difficulty concentrating. And a lot of people also get headaches if they haven't had their morning coffee. next thing here, cocaine. So now, cocaine is the opposite of opioid, right? While opioid is supposed to make you feel relaxed and fall asleep and then die, cocaine makes you feel like a god, right? That's why people have pleasure in taking cocaine. When you do cocaine, you get extreme, almost like manic type of feelings. Like you become a maniac in a sense. So impaired judgment, pupillary dilation, because again it's a stimulant, right? So you can see this is the opposite of opioid. Opioid intoxication causes pupillary constriction because you're ready to go to sleep with that depressant medication or depressant drug. And cocaine intoxication causes pupillary dilation because you're ready to fight somebody with this stimulant drug. It also causes tactile hallucinations, so they feel things on their skin or whatever. Paranoia, angina, sudden cardiac death, which is the reason you're not supposed to do cocaine. Chronic use may lead to perforated nasal septum due to vasoconstriction and resulting ischemic necrosis. So you do check the patient's nasal septum always, regularly, right? Because this is something that has to be snorted into the nose. Treatment, as of course with most stimulants, you give benzodiazepines to treat it with stimulant overdose, and you also have to give a mixed alpha and beta blocker like labetalol for the hypertension and the tachycardia. You can't give them a pure beta blocker because if you do that, then that can actually worsen their hypertension. Because alpha 1 vasoconstriction is occurring, beta 1 vasodilation or beta 2 vasodilation won't be able to occur, so then that's going to be a problem. Now, if you forgot your receptors, again, as always, you want to go back and look at it. Right, so we have in our form section autonomic drugs, right? You have alpha 1 causes vasoconstriction, right? And then beta 2 is the one that causes vasodilation. Beta 1 is just one heart for heart rate and contractility. And if you forgot your beta blockers and how they work, how they're named, you want to make a quick run over to that list of beta blockers and look at this too, right? Where we talk about everything that has N to Z, those are non-selective, right? Almost all of these guys end in the same way in the ending. Their names are all olol. So if they have a different name, then there's something different about them. Right? If they end in ILOL or ALOL, they're usually non-selective mixed beta blockers. This is where we have our labetalol, right? Because ALOL, labetalol. Labetalol is a non-selective one. Very, where they mention it here? Non-selective, right? Nadolol, Pindolol, Propranolol, Timolol. Well, this is non-selective antagonist for just beta 1, beta 2. Then this is non-selective alpha and beta antagonist, which is carvedilol and labetalol. Right? You see how when it still ends in OLOL, that's still working on beta. It's still a beta blocker. A non-selective blocker, which blocks alpha and beta, ends in a weird thing. ILOL or ALOL, and then you know. Okay. And nebivolol is a very unique new one that has NO activity. It does a lot of great things. It also works on the beta 3 receptor. You always want to come back and revise those things because, of course, you need to know it very, very well. So if you just give a beta blocker, then your alpha 1 vasoconstriction is still happening, and you stopped beta 2 vasodilation, so you'll further worsen the alpha 1 vasoconstriction. So you have to give a pure, or you have to give a mixed blocker like labetalol or carvedilol. That one was fine too. The one was ILOL. Now, here, one of the key things you may see in a question is a patient who actually is fighting people, but in a professional setting. There's multiple things here where you're going to see people fighting. PCP can also cause fighting. But cocaine, you don't just go fight someone randomly. Cocaine is actually very commonly, so in New York, it's a running joke that cocaine is commonly used amongst people who work in the financial district, right? People who work on Wall Street, people who work in anything of that type, investment banking, they regularly use cocaine apparently because that's how stressful their job is. Whatever, right? So now what happens with them is you can imagine one day a guy, imagine I'm a financial Wall Street guy, I walk into my investment banking job, I go into the office and someone pisses me off and I punch the guy. That is a giveaway that I must be on cocaine because that is something way out of acceptable, right? That's really not acceptable. I'm going to lose my job. I'll probably never get a Wall Street job again. I'll probably be in jail and life is over, right? This is going to go really, really badly. depending on what action the person that I punch decides to take and what my lawyer can do for me, etc., etc. So that's something to keep an eye on, right? Just because I punch someone doesn't mean I'm on PCP. Why did I punch someone? If I punch someone because they were pissing me off and I was actually at work and I'm doing good normal behavior things, I showed up to work on time, then I must be perfectly fine, but I have a very short temper. A short temper is a common thing seen with stimulants in general. Amphetamines also cause anger, right? And if you mix anger with grandiosity, where you think you're the shit, then that's a very blown up ego, right? So you have to be very careful in picking answer choices. You look for every little thing. Every little thing matters. Every little thing matters for you to be actually able to, correctly pick an answer choice. And then nicotine, again, this is another one just like caffeine. Although not all of us are smokers, nicotine is probably just as much used as caffeine in the whole world. The two drugs that are used the most all over the world are most likely nicotine and caffeine. And I'm not sure which one is more, okay? But we all know what this is about. People who don't get their smoke become very restless. That's all that occurs to them. If they don't get to have their cigarette every hour the way they like to, then they become really restless. And if you've never worked with a coworker that has a smoking problem, then back in college I worked with a guy who had a smoking problem, and every hour he would step out to take a 15-minute fucking break to smoke. It was really annoying to me because he was basically working very few hours. If you're out every hour you leave for 15 minutes, you're barely working. You're barely working. So that's your nicotine guy right there. That's the only issue though with nicotine. They keep smoking and they keep getting really restless every time they smoke. But there's no other major issue. You can see that restlessness not necessarily a giveaway issue. If anything, you could leave this area blank because you can smoke all you want, nothing happens. It doesn't do anything. There's no actual intoxication symptom. But he would smoke and come back and he'd be really restless. He'd be ready to go home. He'd be like he wants to get this done. He would say silly things. I was like, what the fuck? Now, nicotine withdrawal is a big problem. People that try to quit become very irritable, always have anxiety, also have really bad restlessness. They can't concentrate, and of course, all of that causes them to eventually go back to having a smoke. Right? Now, there's multiple things you can give to people to try to help them cope with their smoking addiction. Nicotine patches are not exactly the most um, common thing, if anything. A lot of people don't really even like using it. It's a very easy thing to use. Nicotine gums and lozenges also help. All of these are great initial things, and this is what you will prescribe initially. This is what you're going to offer the patient. You're going to tell them, well, you could take X, Y, and Z, any one of these things you prefer, and it should help you with your addiction to slowly quit the smoking. However, remember that these are still nicotine. So you're still getting the person the nicotine they needed. They're still getting their nicotine dosage. It's just without the actual carcinogens that come with your cigarette, without the actual burning that occurs with smoking, all of that, right? Now, if all of that doesn't really help them and they don't feel like they're doing better, then you can think of bupropion or varenicline. So varenicline, again, we talked about this at the end of pharmacology in step 1 pharm, where this is nicotine decline, right? It's in the name, nicotine decline. And we're going to see this when we get to the pharm section again. I'll go there to show you. The other one is bupropion, which is, again, another atypical medication that you can think of. So let's go to the pharmacology and revisit those two guys specifically. Let's see right here. So bupropion falls, and varenicline as well, both of these fall under the group of your atypical antidepressants. They're atypical because they can help you with depression, but they're actually really helpful for other stuff too. Bupropion is a medication you would give to someone who needs an antidepressant but also needs help with smoking cessation, right? Favorable sexual side effects, so it doesn't really cause any issues that most antipsychotics like SSRIs can cause, where the patient has decreased libido and erectile dysfunction. It's a good medication. The only thing is that you can't give this to someone who would have a seizure. So you can't give it to someone who has a history of epilepsy. The varenicline, also a high yield medication, especially UWorld Step 1 even had a question on it and had this UWorld image to show you how it kind of mimics the nicotine receptor to help you feel better with partial stimulation of the receptor to reduce nicotine withdrawal. It's also an antidepressant. However, it doesn't really have strong antidepressant characteristics. Doesn't really do that good of a job being an antidepressant. Nicotinic acetylcholine receptor partial agonist used for smoking cessation. So when it comes to picking one medication over the other, you would have to see how many things can that one medication help with. You always want to give the medication to a patient if it can help them with 3 to 5 of their problems, right? That'd be wonderful. One pill for everything, excellent. And that's what they're teaching you here. One of the most important things that they don't write here is that when a person has nicotine, not theoretically intoxication, but addiction, one of the most important things for you to do is to actually have the conversation with them that you told them they should consider quitting smoking and that you can help them, right? They may be in the pre-contemplation phase, but you need to talk to them about it, and then you need to document the fact that you did it. You need to write down, I spoke to him about quitting smoking. Patient understands, patient hasn't said anything, or whatever the patient did say. Okay. Last thing we're looking at here, these are your hallucinogens. This is where it kind of gets tricky because this is neither a stimulant nor a depressant, so you have to figure out what the symptoms are based off of whatever's happening. And we talked about ecstasy. Ecstasy is a stimulant. It's a type of amphetamine, so it causes all these amphetamine type symptoms like hypertension, right? Another key thing it causes is hyponatremia, right? And it can often lead to serotonin syndrome. So MDMA is a very high yield hallucinogen answer choice in questions. There are so many ways to ask questions about this, so you can imagine that it pops up a lot, right? Because it makes for great test material. Besides the disinhibition and the fact that this is usually going to be what's used as a rape drug, it causes all kinds of life-threatening issues that you have to catch in the question. So if a patient presents with hypertension, tachycardia, right, and they're kind of euphoric and they're not able to really talk to you correctly, and they're really young, then you can probably safely assume it's a patient who recently must have attended a party or something and got some ecstasy, right? So I wrote here, intoxication may manifest as amphetamine toxicity, so hypertension, tachycardia, and hypothermia. Serotonin toxicity with serotonin syndrome, right? Autonomic dysregulation, high fever, ultimatum status, seizures, and hyponatremia. One of the key things that's often an answer choice. If you see hyponatremia as an answer choice, you should stop and think, and hopefully it'll remind you of this, and you can continue working from there. Hopefully it'll ring a bell. So hyponatremia is a key thing to keep in mind with MDMA. Drug-induced inappropriate ADH secretion, as well as excessive water intake to reduce hypothermia. Right. So the patient is going to be very thirsty. This patient might be in your clinic and they keep asking you for water. Right. So you're going to see those things in questions, and when you see these kinds of characteristics and habits in a patient in questions, it's always there because it's supposed to remind you of something. So if your patient is constantly asking for water and you see hyponatremia as an answer choice, you should be able to connect the dots and think hyponatremia probably is the correct answer. Right? Other one here, LSD. LSD is just a perceptual drug. You also take this in big raves and parties. All it does is it causes visual and auditory perceptual distortions, which then just make the party more fun for these people. That's all it really is. Nothing much should be happening in intoxication. The patient is going to be okay as the drug wears off. LSD is managed in a similar way to PCP management. So let's look at PCP and then we'll come back to that. PCP, phencyclidine. Violence, impulsivity, psychomotor agitation, nystagmus being a key symptom here, tachycardia, hypertension, analgesia, psychosis, delirium, seizures. Trauma is the most common complication. So, like I said, PCP and cocaine both present with someone that's ready to fight you. But the PCP guy will actually come fight you for no reason. They're just violent and impulsive. Right? They're very agitated. They also have nystagmus in the clinic, so you're going to look for that to actually pick PCP as an answer choice. Cocaine and most of these others don't really cause nystagmus. We haven't seen that yet. So nystagmus is also seen in alcohol withdrawal, possibly even alcohol toxicity, but then you don't have all these, in fact, actually it's very easy to make a question look like it could be PCP intoxication or alcohol intoxication. So you're gonna have to figure out which one it is based off of the rest of the symptoms. Now with PCP, trying to restrain the patient is difficult, which is actually what ends up causing more problems, right? Trauma is the most common complication. They will fight back very hard and often it leads to trauma. The best result is from pharmacotherapy immediately. PCP is an NMDA antagonist. Secondarily, it can inhibit reuptake of norepinephrine, dopamine, and serotonin. So what are you going to do for these patients? Well, I have this mnemonic and set of notes I made for myself. PCP, you think of pressure, curled eyes, and problems like violence, right? You want to catch problems. Management of PCP intoxication mostly consists of supportive care, controlling breathing, circulation, and body temperature. Benzodiazepines like lorazepam are the drug of choice to control agitation and seizures. Treating the psychiatric symptoms is also important. Typical antipsychotics like intramuscular haloperidol are used for psychotic symptoms but may produce side effects such as dystonia with the extrapyramidal symptoms, which is okay because they're moving too much as it is. If they start freezing up a little, that might actually be good for them. Similarly, with LSD, LSD is managed in a similar way, but haloperidol is still not recommended due to its side effects. LSD also causes pupillary dilation. Activated charcoal may help within the first hour after an overdose, not fatal. LSD is not that big of a problem. It's not. Patients take it during their parties and stuff, and then they come back just fine, and no big deal. Nothing crazy happens, and they'll be just okay. Last thing in this section itself is marijuana, a cannabinoid. Again, of all of these hallucinogens, this is probably the most commonly used. People in many communities smoke marijuana every single day. No big deal for them. Doesn't eventually at some point doesn't even really do anything for them. They just do it as a force of habit, right? So it's not theoretically addictive. In fact, none of these really are. These are not addictive drugs. These are drugs people take for fun. Okay, whereas the other ones we were looking at before, there is some level of addiction to all of these guys. Caffeine, nicotine, cocaine, amphetamines, alcohol, opioids. There's addiction. These things don't have addiction. There's no addiction. You just have them sitting at home and you smoke it when you feel like it. That's all it really does for you. So with marijuana, one of the key symptoms you'll see in these patients who just had smoked marijuana is this elevated appetite, dry mouth, and conjunctival injection. Not so much for hallucinations. I have a lot of friends that smoke weed all the time. I don't really get to hang out with them anymore because I try to avoid that circle. But back when I was around them and they had started telling me how much they smoke, none of them ever mentioned ever getting any kind of hallucinations. And actually when I was studying medicine, I even texted and asked them, hey, have you ever had any kind of weird things you either saw or heard, any hallucinations while you were super high on weed? They never said anything like that. But in the earlier areas of first aid, they did mention that um, early age marijuana use was associated with schizophrenia, right? So this is related to that, right? The hallucinations. But again, I personally haven't really heard of this. Paranoia is a thing. Patient, any individual who is possibly having their first time smoking weed may present with extremely paranoid response to the weed. It's very common, right? get really paranoid while smoking it. So that's something you may see as well. But generally speaking, there's no real issue here, so you don't really have to worry about picking this answer choice too much. You won't see any major red flag symptoms. And marijuana withdrawal isn't really a thing either. People can stop, at least they say they can. They can stop smoking weed whenever they want to. It's not really addictive, unlike any of these. But if the person was becoming dependent rather than addicted, right? If the patient is becoming dependent on the marijuana to feel good, they may end up having a decreased appetite and depression. Right? So these are some things you look for. A really hard question can mention a patient who may have just moved to a new city, and the city is full of extremely rich people, and it's like a very well-off neighborhood with a lot of police and all of that. They'll mention these weird things, and you're just like, why are you telling me all this? And then the question goes on to say that the patient has now randomly gotten depression, and the patient has decreased appetite, which is a part of depression. They're also unable to sleep, which is also a part of depression. And they're often restless, which is not really a part of depression, but it could be. All these symptoms popped up, but the patient may have 1 to 2 other things that they do that rules out depression. For example, they may still have friends they hang out with, and he does all those fun things with his friends. Excuse me. The question may have something like the patient has no anhedonia, still has a bunch of interests that he really enjoys, like painting or something. So when the patient is doing all these things, and now the picture of MDD doesn't really fit, then of course, because he moved to a new city, you might think of adjustment disorder, right? AD. But adjustment disorder doesn't really have depression. So when you see a question like this, where the patient is showing some symptoms of depression, but they're not really depressed because they have some symptoms that never fit in depression, a depressed person will always have anhedonia. It's like a thing. Either they'll have anhedonia or they just won't have any interest. But if a depressed person is out there enjoying things they are interested in, that is not a depressed person. That would be a person who may be now going through marijuana withdrawal because they moved to a new city where they no longer have their hookup of who's going to bring them the marijuana. Very hard question though, so you have to be very careful with that, because acute stress disorder is what we think of for a person who recently moved. MDD is what we think of for a person presenting with all these depression related symptoms. So you got to be good at ruling things out simply based off of the 1 to 2 few symptoms you're catching. Okay, and at the bottom here they mention alcoholism. Now this can also get very difficult. So alcoholism in general, we're going to look at that when we get CK. Physiologic tolerance and dependence on alcohol with symptoms of withdrawal when intake is interrupted. Complications include alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, testicular atrophy. Treatment is disulfiram to condition the patient to abstain from alcohol. Acamprosate, which is actually something that can cause diarrhea and abnormal heart rhythms. You have to avoid use of it with patients with kidney problems, and side effects include some suicidal behavior. So you don't really want to prescribe this, but it enhances GABA signaling via allosteric modulation and reduces glutamate surges, which is the opposite of what you're seeing here. So that's all acamprosate is. It's a very strange medication. They would have to mention a lot of things for you to actually pick that as an answer choice. Otherwise, no, don't pick it. And naltrexone, which was also related to opioids, it reduces cravings. Support groups like Alcohol Anonymous are helpful in sustaining abstinence and support patient and family. Now, Wernicke-Korsakoff is caused by BU1 deficiency, which we learned about most of these things back in biochem earlier. Triad of confusion, ophthalmoplegia, and ataxia may progress to irreversible memory loss, confabulation, personality change. Symptoms may precipitate by giving dextrose before administering vitamin B1 to a patient with a deficiency. Associated with periventricular hemorrhage, necrosis in mammary bodies. Treat IV vitamin B1 and then dextrose. Remember, you can always give someone a vitamin, but you can't always give somebody sugar. Right? So that's the general idea that you're trying to catch there. And here's a very, very interesting question where this is exactly what's happening. Extremely fancy question. I'm going to post it right here so you can see it. It's a screenshot, and then we'll go into our CK book. So this question was pretty well written, but again, this is one where you would arrive at the correct answer by ruling out everything else. 39-year-old woman is hospitalized for appendicitis and undergoes an appendectomy in hospital day 1. So you always know when a patient is being hospitalized, the first thing you should think of is, oh my god, I hope they're not an alcoholic. The patient has an uncomplicated postoperative course until the morning of hospital day 3. So now they've been in there for more than 48 hours. So DT, delirium tremens, is a potential reality for their life now. Day 3, when she suddenly becomes acutely agitated. Boom, giveaway, it must be alcohol. It should be the first thing you think of. Be confident. She tries to get out of bed and shouts, "Get your hands off me. God is watching." When the nurses try to redirect her back into bed, the patient has a history of schizophrenia, hypertension, multiple substance use disorders, and homelessness. So they're telling you she has a history of schizo just to confuse the shit out of you. Medical records indicate that she was treated for a heroin and cocaine overdose last year, and she's had multiple admissions related to her substance use, probably the alcohol. Vitals show elevated temperature, so she's very febrile, which is also confusing. Blood pressure is extremely high. Pulse is fast. Respirations are 18. The patient is oriented only to person. She's diaphoretic, but the remainder of the exam is limited due to agitation. What is the most likely cause of her condition? This was a patient with alcohol withdrawal. This is actually a question that's harder than 68% of people getting it right. So I was very interested and very excited to see that 68% of people got this right. This is a hard question because alcohol withdrawal, theoretically, most people don't really ever remember, can cause fever. It's not really a thing you think of there, right? So, where was it? In fact, it's kind of shitty how First Aid CK has the smallest line for the most important topic, alcohol withdrawal. But they probably did that because they have an entire section about it, right? So they have this entire section here. And withdrawal, they do mention, thiamine and all these things, but they don't really list out too much. And then they go into this stuff of alcoholics hallucinosis versus delirium tremens, and this is where they tell you there's autonomic instability. The autonomic instability is what's the elevated blood pressure as well as some hyperadrenergic fever. That's what's happening there. So our patient is going through alcohol withdrawal. Very interestingly worded question in that, the one we just looked at, where it's actually alcohol withdrawal, and it's just so weird. This question is the one I put it in the book here too, right? So you can see it, alcohol withdrawal, 39-year-old woman with appendicitis. Although a lot of people got the question right, it was very difficult to identify. You have to know all the things you would see in delirium tremens. Right? It's a very key little thing to catch. Let's just see something else. Yeah, okay, that's about it. So you have to know confidently what you're looking for, and you have to be able to rule out other answer choices simply because you know it doesn't fit. That's it. You just know that it makes no sense, so you don't pick the other thing. If it doesn't fit perfectly, you really don't want to fall into a pattern of trying to make the thing fit. Right? Don't make something fit. It should fit by itself. So let's look at now, actually. Now that we've kind of talked about all of them, we'll read this real quick and then we'll look at practice questions. So right here, they talk about alcohol use disorder. You have your CAGE questionnaire. Occurs more often in men and in those who are 21 to 34 years of age, although the incidence in women is rising now. Associated with a positive family history, see the table for symptoms of intoxication and withdrawal. Look for palmar erythema or telangiectasias, and for other signs and symptoms of end organ complications, because remember, the palmar erythema and telangiectasias are a sign of liver dysfunction. You're looking for liver cirrhosis type of symptoms. Patients often present with sleep disturbances or anxiety symptoms caused by mild withdrawal. So if you have difficulty thinking of what you should see, like if you close your eyes and imagine what an alcoholic person looks like, then this is what you should look for. It's going to be someone who looks like, let's see, this guy right here. Minus the age part, this looks like a really old person. But these are some of the things you're looking for. You see the palmar stuff, palmar erythema, spider angiomas all over the body, caput medusae, right? Some kind of jaundice occurring. Asterixis, his hand is shaking because of the hyperammonemia that's occurring now because of liver failure. Right? All kinds of things that occur. These are all things that are occurring in this person because of liver cirrhosis. The liver is not working anymore. And when the liver is not working, that's, you wonder why it's not working, and one of the major things could be that it's not working because the person is an alcoholic. Right, so that's all you're thinking of there. Screen with the cage questionnaire. Right? Have you ever felt the need to cut down on your drinking? Have you ever felt annoyed by criticism of your drinking? Because if they felt annoyed by others telling them something about their drinking, they're an alcoholic. No one's going to tell you, oh man, you should probably quit drinking, outside of religious reasons. No one's going to tell you you should probably quit drinking unless they know that you're drinking too much. Have you ever felt guilty about drinking? Very common scenario. People drink, they end up missing some kind of event they were supposed to go to, maybe their daughter's graduation or something, along those big caliber lines, and then they're forever guilty about it. Forgot to pick up their son after school, then guilty about it. Have you ever had to take a morning eye opener? As soon as you wake up, you take your gulp because you just can't start your morning without it. More than one yes makes alcoholism likely, but theoretically speaking, even one yes does make alcoholism likely as well. All right, so you have to be very careful with that. And this isn't exactly the most sensitive and specific way of figuring out if someone is an alcoholic, but it does help do the job figuring out if someone is, to some level, either actively an alcoholic or about to become an alcoholic. Labs may reveal elevated LFTs, especially the alcohol Scotch tonic AST 2-to-1, high LDH, high carbohydrate deficient transferrin, and high mean corpuscular volume. This probably being one of the most weird answer choices you'll see, and that you may not want to pick it. Right? So you have to know it pretty well so you can pick it. Carbohydrate deficient transferrin. Right? That's something you see in an alcoholic. Treatment, of course, abstinence, quit drinking. Best initial treatment is naltrexone, a mu opioid receptor blocker, same thing you were using for opioids. Decreased cravings can start while patient is still drinking. Long-term rehabilitation, Alcoholics Anonymous. Aversion, like disulfiram. Right? Disulfiram causes this really weird taste and almost nausea and vomit every time they drink alcohol. Right? So whenever alcohol is consumed, they get a really weird flushing, nausea, vertigo, and palpitations. So that's going to cause them to not take it anymore. It's almost like shocking yourself every time you drink. And then, of course, for withdrawal, stabilize vital signs, correct electrolyte abnormalities, give thiamine before giving dextrose, right, to prevent Wernicke encephalopathy, start medium-length benzodiazepine taper, add haloperidol for hallucinations. Now, Wernicke can get tested in a very interesting manner. You can get a patient who came in for whatever issue, got hospitalized, and you were checking all their work, and you noticed that their glucose is low, so you infuse them with more dextrose. And then the next morning, they have no idea who they are, what they're doing, and all kinds of weird things, because you just triggered their Wernicke encephalopathy by giving them dextrose without giving them thiamine first. Again, any question about someone being hospitalized and acting weird the next day, you should immediately think the problem is probably related somehow to being an alcoholic. Right? That's the concept you're kind of sort of working with there. Complications: gastritis, varices, Mallory-Weiss tears, pancreatitis, liver disease, delirium tremens, alcoholic hallucinosis, peripheral neuropathy, a bunch of things that can occur. Aspiration pneumonia, anemia, right? This occurs everywhere. And then just like how opioid withdrawal caused neonatal abstinence syndrome in the neonate, fetal alcohol syndrome is another thing that you have to keep in mind for your obstetric questions where the mom didn't stop drinking alcohol. Most questions about fetal alcohol syndrome or neonatal abstinence syndrome will also tell you that the mom had minimum or no prenatal care or perinatal care, that the mom didn't come into the clinic at all, did an at-home delivery. These are usually moms that are shy to come to the clinic because they'll get exposed, that they're drinking or smoking or whatever while being pregnant, because they're obviously selfish like that, right? So you want to watch out for that in questions. Alcoholic cerebellar degeneration occurs after 10 years of heavy alcohol use. Degeneration of the Purkinje cells in the cerebellar vermis is what mainly adds into causing eventual ataxia. Wide-based gait, incoordination in legs, cognition is usually intact. Diagnosis is clinical. CT or MRI will, of course, show you. Treatment is alcohol cessation and nutritional supplementation. Right? That's all you can ever do for these people anyway. So you try your best and you do it for them. so let's see where the practice questions begin from. Okay, right here. Just want to see is there anything. Oh, okay. Yeah, so let's just run through this real quick. Just the cocaine part. This was a really interesting question. So cocaine, as we talked about, right? Psychomotor agitation, euphoria, impaired judgment, tachycardia, pupillary dilation, hypertension, paranoia, hallucinations, and they get these tactile hallucinations called cocaine bugs, where they say they feel something running on their skin. Sudden death, of course, due to cardiac causes. Chronic use can cause weight loss, erythema of the nasal turbinates and septum, and behavioral changes. ECG changes from ischemia are often seen as cocaine chest pain. Treat with haloperidol for severe agitation, along with symptom-specific medications to control hypertension. Like we said, the mixed beta blocker with some alpha blocking, like labetalol. Now here, this was a really interesting answer choice in some question. Cocaine intoxication may cause patients to act extremely powerful and godlike, with high blood pressure and dilated pupils, right? Extreme sympathetic activity. A key feature is self-resolution without treatment, followed by acute, short-lived depression. So this is basically a person who does cocaine, goes to work, maybe fought their co-worker like I explained earlier, got hospitalized for this acute psychosis, so they're safe, they're not going to end up in jail, and then you did absolutely nothing for them besides minimum symptomatic management, and the next morning they're okay. So they're okay, that's because the cocaine wore off, and they're fine now. And then they'll tell you, yeah, I always do this, and then I'm so depressed the day after. Yeah, that's cocaine, right? So the answer choice for long-term cocaine abuse treatment was to do individual psychotherapy with 12-step groups. 12-step groups like Cocaine Anonymous. So a 12-step group, I didn't know what that was until I looked it up. Right, so Cocaine Anonymous is a 12-step group where they have their little diagram of 12 steps they take care of to help patients with their addiction problems. Again, things you probably don't learn about in the book and may not have heard of before. So it pops up in questions, and that's the beauty of it. The rest of these things are pretty much still the same. The only thing that's new here in CK is this thing, bath salts, which are synthetic cannabinoids, right? This is a stimulant drug that causes agitation, combativeness, and delirium, and psychosis that can last for weeks. So that's what makes it unique here. You got the drug only once, but your symptoms lasted for weeks. Most of these other things, the symptoms don't last for weeks. Within 24, maybe 48 hours, the symptoms will still be there, and it'll either kill you or maybe something was given to you and you'll get better. But the bath salts are very unique in that the symptoms last for weeks. This almost PCP type of agitation and combativeness. But remember, PCP has the C for curled eyes for nystagmus, which we're not going to see anywhere really besides PCP. So we jump into the questions, and of course I made sure the first question I put here is for the synthetic cathinone intoxication. Now, you're going to see here that people are struggling big time in getting the questions correct because people are just lost. A lot of the answer choices often seem similarly correct or equally right, and it's really hard to differentiate one over the other because you just can't. Let me see. Alright, so first question here. 37-year-old man brought to the ED. Police found him running into traffic, yelling obscenities at drivers, slamming his body against passing cars, and trying to break windshields with a beer bottle. So that I would call like having a godlike mentality, right? Pretty much thinking he's Superman or something. A witness described him as having crazy rage. In the emergency department, he remains combative with police, and 4 officers are needed to restrain him. He is disoriented, continues to yell, and appears to be responding to internal stimuli. So thinking of something in his head. Grab my pencil. Temperature, blood pressure is really high. Pulse is fast. Exam shows clear lung fields. Abdomen is soft and untender. Extraocular movements and cranial nerves are intact. Upper and lower limb deep tender reflexes are high. Labs show nothing. Very, very key here. Okay. While in the ED, he has a seizure and is treated with benzodiazepine for both the seizure and the agitation. Perfect. He's admitted to the medical service and treated supportively. He remains psychotic for the next 2 days. Right? Remains psychotic for the next 2 days, but his symptoms begin to subside and eventually resolve. What is the most likely explanation for his presentation? So this question was a giveaway question for synthetic cathinone intoxication, but only 40%. It's a half and half. The other half of people very confidently and happily chose PCP. They must have been so proud, right? Because they caught that this question is showing a guy who's just out there punching, causing violence, right? But PCP intoxication, as we saw, does not cause just that, and it's not one of the guys that lasts for 2 weeks or something like that. PCP is a hallucinogen you would take. It would only work for the day you took it, and then the next day you'll be okay. That's it. Of course, trauma is common, and everything else here fits. This entire scenario, this whole checklist of shit, fits perfectly in the question we're looking at. Right? Violence, impulsive, agitation, tachycardia, hypertension. Probably doesn't feel much pain, psychosis, delirium, even has a seizure while being hospitalized. The one thing you did not see in the question was nystagmus. Never did they mention he had curled eyes of any kind. In fact, when they did extraocular movements, it was fine. Right? Extraocular movements are intact. You always check the eyes for people coming in like this, right? Because it could be opioid, so you're going to look for the dilation or constriction based off of withdrawal or overdose. So this was a very good question for those few reasons. So because the extraocular movements are normal, and because he remained psychotic for 2 days, this guy must have done synthetic cathinone. Right? Synthetic cathinones, commonly referred to as bath salts, consist of a large family of amphetamine analogs. As such, they may increase the release or inhibit the reuptake of norepinephrine, dopamine, and serotonin, which all ends up causing you to be very crazy. Remember, norepinephrine is your fight or flight hormone from the adrenal gland. Excuse me. Dopamine is your psychosis hormone. That's what's really high in schizophrenic patients. And serotonin is supposed to be your happy hormone, but if it's too much of it, you're going to act like you're the happiest guy on earth and just go crazy. Symptoms of intoxication include severe agitation, combativeness, psychosis, delirium, myoclonus, and seizures. Increased sympathetic outflow may lead to significantly high blood pressure and heart rate. The most distinguishing feature is the prolonged duration of effect. As I said for you guys, it may last for weeks. Delirium and psychosis due to synthetic cathinones may last up to a week, whereas the effects of intoxication with amphetamines or any hallucinogen like PCP are usually of much shorter duration. The same day, it's a one-day thing. That's it. PCP intoxication presents with psychomotor agitation and all the same symptoms, with tachycardia and hypertension, as well as multidirectional nystagmus, which the patient didn't have. PCP symptoms are of shorter duration and is a part of standard urine toxicology, which you need to know. So now you need to figure out what is part of standard urine toxicology. But it's part of the standard urine toxicology, and when they did the urine toxicology for our guy, they would have found it, but they didn't. There was nothing in his urine. Right? So that was how you know that it's not related to that issue. Right? Next one, 17-year-old boy is brought to the emergency department by his parents due to a recent change in behavior. So young teenager. Okay. He was previously polite and soft-spoken, but he has become intermittently irritable, impatient, and rude over the past few weeks. Okay, so I'm just going to highlight rude for this guy. His parents initially dismissed that he had stolen money from their wallets and later found him packing his room at 4 a.m. When questioned by his dad about his strange behavior, he said, "I have to be careful because I'm being followed. Being followed by CIA agents." Right? So that's obviously some level of psychosis, some level of paranoia. He has no medical conditions. His father has chronic pain and insomnia, for which he takes oxycodone and diphenhydramine. This patient, his blood pressure is super fucking high. On physical exam, he appears fearful. He's sweating profusely. Pupils are dilated. He is observed in the ED for several hours, and his condition improves, and he is discharged to the care of his parents. So his condition improves by itself without having to do anything. So what can you take to cause your pupils to be dilated, to get all sweaty, to have some level of paranoid psychosis, and have a super high blood pressure, but then without doing anything at all, over time, it all goes away? amphetamine. That's it, right? It's amphetamines do cause hypertension. They do make you very aggressive. They do cause you to have dilated pupils because it's a stimulant, and your heart rate will be up, so you will be sweating. And you don't need to do shit; it'll get better by itself as well, at least the first time. 12% of people chose anticholinergic poisoning, which again, organophosphate poisoning questions are almost always a farmer or someone working in some garden. How does that fit here, right? Also, anticholinergic poisoning means that you have uh, too much acetylcholine. If you have a lot of acetylcholine, then that would be rest and digest, which means your pupils would be constricted. So that doesn't fit, right? And 20% of people chose opioid withdrawal. Now, opioid withdrawal would have pupils dilated, but and it would cause the patient to act like a stimulant type of thing because they're having withdrawals from a depressant. But opioid withdrawal, we already know, causes flu-like symptoms, right? They look really fucking sick and they look like they're in a lot of pain. Not like this, and there's no paranoia with opioids either. Right, so you have to pick on the key little things here and there to be able to actually rule out other answer choices and easily figure out exactly what's happening. Right. His episodic agitation, insomnia, psychosis, change in behavior, and signs of sympathetic hyperactivity with subsequent return to baseline without doing shit, right, just a period of abstinence, are consistent with amphetamine intoxication. Potential serious complications of amphetamine intoxication include arrhythmia, seizures, and hyperthermia, as well as intracerebral hemorrhage because of the extremely bad end organ damage that you can get from hypertensive emergency if it occurs. Diagnosis is clinical, and positive toxicology screening can be supportive. However, the decongestant pseudoephedrine and the antidepressants bupropion and selegiline can cause false positives for amphetamines. Gotta be very careful with that. Right? False positives for amphetamines on urine toxicology. Some symptoms of anticholinergic poisoning can occur due to amphetamine intoxication, but anticholinergic poisoning is differentiated by the presence of dry skin, motor symptoms, and other classic anticholinergic manifestations like ileus and urinary retention. Right? And anticholinergic, anti-acetylcholine. Oh, right, I explained it incorrectly. Anticholinergic poisoning is like not having acetylcholine, right? Not I was explaining an acetylcholinesterase inhibitor, but anticholinergic poisoning means that you don't have acetylcholine, which means you don't have parasympathetic output, so you would have a lot of sympathetic output. And yeah, we are seeing some sympathetic output, but you would have full-blown rest or digest, right? Too much acetylcholine, full-blown rest or digest. We don't see full-blown rest or digest either. You know, he's just having some level of stimulant activity. He's stimulated to do really weird shit. And then opioid withdrawal, as I explained, right? We don't see any of his opioid withdrawal symptoms either. So those answer choices that 30% of people picked feels a little weird to me. You know, you got to make sure you're thinking very concisely and clearly when you're picking these answer choices, and you should, as you're reading the question, arrive at the most likely scenario really quickly in your mind as you're doing it. Right. Next thing, 17-year-old girls, same age. Now we have a female. Is brought to the office by her mom, who is concerned about her daughter's weight loss and mood changes. Okay. She has lost, oh wait, I never really tend to highlight things in the first sentence, so we start from here. She has lost 10 pounds in the last 2 months and has been irritable. Okay. The mom says that she has suddenly become a picky eater and that she now often refuses to eat, insisting that she is just not hungry. Right, so refuses to eat. Mom also worries that her daughter is not sleeping enough. When questioned about these concerns, she denies having any problems and says that she feels fine and has lots of energy. Okay, so that's something possibly manic. She adds, "Isn't it healthy to be thin and fit? I don't understand what my mom is worried about. Her height is 5'2", weight is 105. Physical exam shows a thin body habitus, erythema of the nasal mucosa, and mild facial acne." So she's got some acne. What is the most likely diagnosis? So the giveaway in this entire thing was the erythema of the nasal mucosa. She must be doing cocaine. That's it. Right? These kinds of answer choices of doing cocaine or having amphetamine intoxication will almost always show up with someone extremely young because they don't know how to do it correctly, and someone might have given it to them and they overdosed. That's it, right? So cocaine is a stimulant that produces increased energy, which she described. decrease appetite, just like an amphetamine would, and reduce need for sleep. Individuals who abuse cocaine often have mood changes and weight loss secondary to decreased appetite. The diagnostic hallmark in this scenario is the erythema of the nasal mucosa, which is a common finding in individuals who snort cocaine. In severe cases, perforation of the nasal septum can occur. In addition to mood disturbances, other side complications of cocaine include anxiety, panic attacks, grandiosity, and psychosis. The physical finding of erythema of the nasal mucosa, a normal weight, and lack of other characteristic features of eating disorders make these diagnoses less likely. Right? So the other people chose anorexia nervosa or avoidant and restrictive food intake disorder, whatever that is. In those things, you would have a discrepancy between desired and perceived body image. We don't see that. She doesn't think that she looks ugly or that she needs to lose weight. She simply said, "Oh, I'm fine. Isn't this great how I am?" Then she's right. It's okay the way she is. Being thin and fit is healthy. Yes. So that those kinds of wording of things was what helped you knock out anorexia nervosa, which would have a low BMI, and avoid a restrictive food intake disorder, where you avoid food and very minimally eat food, but it's actually a disorder that's occurring due to wanting to lose weight and not perceiving yourself okay. So here is a table showing you the standard urine drug screen. When you order a standard urine drug screen, you're going to be ordering a screen for all of these things: amphetamine, cocaine, cannabis, opioids, and PCP. However, unfortunately, there are a bunch of other medications or things you could take that can cause false positives. Right? So you have to be careful with these false positive things, because a patient may be taking some of these medications and it's always a hard question. If you get a false positive bullshit question, it's initially very, very hard until you figure out the trick, right? For example, imagine a patient is hospitalized and they're having no real symptoms. They're just hospitalized. No real symptoms. They came in because of some issue that occurred. They're not presenting with any overdose symptoms, but they're acting a little weird. And they give you a list of medications the patient takes, and they tell you that they did a urine drug screen and the patient is positive for amphetamines, but then the patient doesn't really have any symptoms of amphetamine shit. Then you go back to the list of medications and you look at anything they may be taking that may be an amphetamine type of medication. Remember what an amphetamine does: decrease norepinephrine uptake, increase the dopamine stuff as well. So you're looking for something that would affect all those things, like bupropion, or just these two beta blockers, a couple nasal decongestants like diphenhydramine. It's a lot of weird shit. The way you would get this correct is because you'll see that the urine drug screen told you something's wrong, right? They're having certain drugs in their urine, but then they don't have any history of anything. Their psychotic history is fine. Their hospitalization history is fine. Everything about them is fine, and they deny it. So then that's the point that you should pick an answer choice for what is actually wrong. Right? This kind of question will most commonly present with someone who probably had to do a drug test for work, right, for a job they're applying or something, and then they didn't get the job because they apparently had positive for one of these things, and you're gonna have to tell them, you're probably gonna have to write them a letter so that they can bring it to their boss or future boss that it was a false positive, right? So that's the kind of thing you're looking for. With false positives, you won't have a whole scenario of symptoms. Okay, that's the key feature of all that. Here, 37-year-old man brought to the ED by police officers, found naked at a traffic signal, cursing at drivers and assaulting nearby pedestrians. He has a history of abusing multiple substances and has been admitted to the hospital several times with similar presentation. He has epilepsy and DM2. Attempts to elicit a history from him prove unsuccessful because he is highly agitated and combative. Keeps repeating, "They are all out to get me. They are coming through the walls, ready to kill me." He alternates between screaming and pounding on the walls. Vitals are showing a little high blood pressure. Physical exam shows ataxia, nystagmus, and muscle rigidity. The nystagmus is a giveaway. In combination with his fighting and violence, right, PCP, the C was for curled. curled eyes, right? Nystagmus. So what's the best step in his management? Even if you couldn't really figure out this was PCP, lorazepam is still the correct thing to give him because he's very agitated. So you need to give him something that will make him less agitated. Right? Lorazepam, his presentation suggests PCP intoxication. PCP acts on the NMDA receptors, particularly in the hippocampus and limbic system, causing excitatory and psychotic effects. It also acts on dopamine, norepinephrine, and serotonin receptors, causing adrenergic and dopaminergic effects of psychosis. Lastly, it acts on the sigma receptor complex that you don't really need to worry about, causing psychotic and anticholinergic effects. Thus, PCP intoxication commonly presents with severe agitation, delusions of enhanced strength, psychosis, paranoia, hallucinations, analgesia, and aggression. Physical exam shows multidirectional nystagmus, which is the key giveaway. Right. Here we have a question where the correct answer was oxycodone, but 20% of people chose heroin. 47-year-old man is brought to the emergency department following a single-car motor vehicle accident. Physical injuries are relatively minor, but he appears intoxicated. He has a known history of polysubstance abuse. He is sedated and slow to respond to questions, so he's sedated. Abdomen is soft, non-tender, bowel sounds are decreased. So that's kind of like saying that if he was okay, that if he didn't go through this car accident, he would probably be constipated because his bowel is not making any sounds, so food and poop is not really moving around. Extraocular movements are intact and pupils are 1 millimeter. So this always sucks when they do this because now you don't know if that means that the pupils are dilated or constricted. Okay. Physician suspects intoxication and orders a standard urine drug screen, but the screen is negative. What substance is he most likely using? Okay, so this is a question once again on something like this, understanding what the standard drug urine screens are, right? And understanding what his symptoms are for. His sedation, mild respiratory depression, decreased bowel sounds, and meiosis are classic for opioid intoxication. A standard urine drug screen tests for amphetamine, cocaine, cannabis, PCP, and opioids. As in the table to the left. However, it is important to remember that the standard tests performed by immunoassay identify opioid use by measuring morphine, a breakdown product of all natural opioids, heroin, codeine, even poppy seeds. Okay? His negative opioid result on standard drug screen is best explained by the illicit use of oxycodone, a semi-synthetic opioid. Gas chromatography or mass spectrometry is a highly sensitive and specific technique that can be used to verify false positives and false negative results. Heroin and morphine and natural opioids that would test positive. Heroin and morphine, actually, morphine was another answer choice, are natural opioids that would test positive on a standard urine drug screen. Okay, but oxycodone is not a natural one; it's a synthetic one. Why would you know that? You probably wouldn't. So you learned it from this question, right? Also, poppy seeds, interesting little fun fact that I never really verified, probably is a fact though, are actually illegal in Saudi and a couple other countries. You can't bring poppy seeds to Saudi Arabia or you may actually get arrested and possibly even killed because of the fact that it is theoretically an opioid. Right? And people who eat things every single morning that have poppy seeds on it, it's often found on some breads and buns, would actually start having opioid relevant symptoms. So a person that tells you he eats a certain burger every single or a certain bagel every single morning and it has abundant poppy seeds on it, and today he's popping into the clinic because he's got constipation, that's a sign that the poppy seeds are causing opioid induced constipation. The opioids in the poppy seeds are not strong enough to cause pain relief, but remember the most significant features of opioids that no one can ever become resistant to is the constipation and the pupillary dilation that occurs. Right? Those two things you don't gain resistance to, you don't gain tolerance to, it always occurs. Right? So those something weird. So you can see the false positives table here is what's the most unique thing on CK for drug overdose questions, and it's easily something that can become very difficult. Next one here, 63-year-old man comes to the office for a routine follow-up a month after being prescribed morphine for chronic treatment-resistant back pain. He says that his pain is greatly reduced since starting morphine. He has been able to begin a light exercise regimen for the first time in over 2 years. Other medical problems include hypertension, allergic rhinitis, diabetes, and major depression. Wow. Vitals are looking good, although pulse is on the lower side. He has a normal range of motion of the spine, and movement is associated with a reduction in pain compared with previous exams. As part of prescription drug misuse monitoring, the physician performs a random urine drug screen that is positive for opioids and PCP. He insists that he is not taking PCP, which med could cause a false positive result on his urine drug screen. You see how this just becomes really annoying now? This is a very CK type of question. You would probably never see this on step 1 unless they're trying to be an asshole and give you this as a step 1 question. Now, do you actually have to remember all the things that cause PCP? Or each one of these things that cause false positives for all the drugs? Yeah. You don't have to remember it to a point where you can recall it without looking at the list, but you do need to remember it to a point where when you see it as an answer choice, it should ring a bell and you get it right. Right, those are two different levels of memory. One memory, where you can recall it without the book in front of you, is perfect memory. You have full recall. The other one is slight recall, where when you see the answer choice, you'll know that's the answer because you'll remember. Right? So dextromethorphan, diphenhydramine, doxylamine, ketamine, tramadol, and venlafaxine, your SNRI, can also all look like PCP. In fact, he may even be on venlafaxine as well for his MDD. So the correct answer here was dextromethorphan. 30% of people chose phenylephrine, which I honestly don't know how they did because it's not anywhere here. Phenylephrine is like epinephrine and norepinephrine. Why would this thing look like PCP? Just think about like the PCP test. Like, why does phenylephrine have anything to do with PCP? It doesn't. Standard urine drug screen typically tests for things in the above table. They're usually performed by immunoassay, which can yield false positives. Right? PCP has many common meds that can yield false positives. So you have to do the gas chromatography. Phenylephrine, as well as some other drugs, may cause false positive test results for amphetamine, but not PCP. In fact, even for amphetamine, it's not really a thing. Now, phenylephrine does make sense to possibly cause a false positive for amphetamine, because remember, phenylephrine is like norepinephrine and epinephrine in those guys. It works on alpha receptors and stuff like that, just like amphetamine does. Amphetamine also works on the alpha 1 receptor. So that connection that it says may cause makes some relevance, some logic to it. No logic for phenylephrine having to do anything with PCP. Alright, so again, you can see how stupid these questions are going to be about urine drug screen false positives. Last question on this page. 21-year-old college student is brought to the emergency department by ambulance. His friend saw him swallow an unknown substance at a concert party. Soon afterward, he appeared to be interacting with others at the party. So whatever he took at this concert now had him interacting with others, so it must have caused disinhibition, right? It made him more confident. A few hours later, however, he seems disoriented, appeared flushed, and was sweating. When emergency responders arrived, they found him having a seizure. He was stabilized en route where his seizure stopped. He has no active illnesses except for history of depression, for which he takes an SSRI. So now we're thinking whatever he took may have interacted with his SSRI. He takes no other meds, temperature is super high, blood pressure is super high, he's still flushed and diaphoretic, his reflexes are up, he has some myoclonus, and he continues to be disoriented. Lab results are unremarkable except for a serum sodium level of 121, hyponatremia. What substance is the most likely cause of his condition? Ecstasy. They didn't need to tell you all that, but of course UWorld questions tell you everything, so you can see the full picture of things that go together. Right now you know everything that goes together. MDMA is probably one of the most significant of all your hallucinogens to be tested, because the others are all too easy. LSD is simply something where you look at silly things. Like, you got to come up with LSD. I don't have a mnemonic for it, but you can come up with some kind of mnemonic with LSD, because it's all it is. You're looking at things, or looking at something distorted. I guess you could think of it like that. It just causes distortions. It's for parties. The music sounds better. The things look all wavy and colory. You know, that's how they describe it in cartoons. That's all it is. Very straightforward. In fact, if you want to spend a little bit of time to get a better understanding, you can YouTube LSD intoxication, and then you'll see some videos of people showing you what it feels like. Same thing with PCP and MDMA. Right? Look for clinically relevant ones, not funny ones people made. Now, MDMA has the biggest group of symptoms because it does a lot of shit. Each one of these is a heavy ass word. It causes serotonin syndrome, it causes hyponatremia, it causes hypertension, it can cause bruxism, right? It causes distortion of sensory stuff, tachycardia, hyperthermia, so it can mimic malignant hyperthermia, hyperactivity. It has a lot of things it can do. But the clinical scenario should fit. This is a young college student who just took a drug to become disinhibited, ecstasy, straight up. It's not going to be LSD because LSD would be for a rave, not really a party like this. And if it was LSD, he would have no symptoms at all, nothing. He would just go have fun. That's it, right? And it's not going to be amphetamine, really, not something you take at a party. Amphetamine was for focusing to study, right? So again, the clinical scenario has to fit. If they give you a question without a clinical scenario and just tell you, hey, a patient came in looking X, Y, and Z, then it's a little harder, but even then you use your best logic. So you can see that they combined everything into this one question, especially when they add the SSRI, because with an SSRI combined with MDMA, that's going to yield serotonin syndrome, which is what he's going through. Right, so that's what they're describing here, and that's his full breakdown of shit. And great questions overall. Great questions overall. Make sure you revise it all, and then in our next session, we'll move on to more practice questions over here regarding alcohol, and then we'll dive right into the eating disorders. All right. So thanks a lot for joining, and I'll see you guys later tonight.